this algorithm. So we can also use an insulin pump, which is continuous subcutaneous insulin infusion, CSII. When the uterine activity is regular and the patient's having clear non-caloric fluids, we can cut the basal rates by 30% of the last pregnancy setting. And when they're in active labor, we cut by 50% of the last pregnancy setting. And again, they don't need as much insulin during labor. If a correction bolus is needed for a blood glucose over 110, we can use half the pregnancy correction bolus and recheck the blood sugar in 30 minutes. So if you have a high blood sugar, try to figure out what's happening with that. Is the patient infected? Did they get a beta-mimetic like ephedrine or terbutaline that may have raised their blood sugar? Are they in severe pain, or are they anxious, or is the IV dextrose running too much? So treat the source first. Check again to make sure that the blood glucose target, that you're able to achieve that target within 2 hours of making any of the changes that you might make. If you're not, then you need to talk with the doctor and adjust adjust the insulin infusion. So check the blood sugar every 30 minutes when you are not in target. And again, checking the blood sugar is the most important intervention you could have. So how do we treat the hypoglycemia? So if a patient's blood sugar is running 50 to 70, these orders must be in the chart. You have to have orders for hypoglycemia if you're running an insulin drip. So, or if you're dealing with anyone who is taking insulin, you have to have orders for hypoglycemia. So you don't run to the phone and notify the doctor. You stop the insulin so that the patient no longer is in danger. So stop the insulin infusion, infuse glucose at 200 milliliters per hour, and then check in 15 minutes. You may bring that person right up above 70 within 15 minutes. You need to be over 70 times 2, and when the glucose is that way, then reduce the D5 to 100 per hour. You could even reduce it to 50 per hour. It depends on the dosing that your doctor wants. So then you notify them, and they may adjust insulin dosing and they may adjust glucose dosing. Be prepared for, at delivery, be prepared for possible abnormal fetal heart rate. If the blood sugars are too high, it should be fine if they're not too high. Abnormal labor if you have a macrosomic baby. Preeclampsia, choreo, shoulder dystocia. How do you prepare for shoulder dystocia? From the outset, you talk with mom about the fact that when she's delivering the baby, we might ask her to bring her legs up. You show her how to do that, the McRoberts maneuver to open her pelvis, and so that when that happens, it's not a terrifying event. She's going to know, oh yeah, I'm opening my pelvis up. I need to grab underneath my knees and pull back towards my ears, and she will know what to do. Be prepared for an emergency C-section. Make sure that anesthesia and OB are available, and peds, if you think there is a big high risk for emergency C-section. Other newborn issues would be hypoglycemia, and if the baby is delivered by C-section, transient tachypnea of the newborn, which is not RDS. It's just the baby hasn't been squeezed as it went through the birth canal because it came out the other way, and so the lungs are full of water, and that needs to the baby has to breathe rapidly to get rid of it, and that would be the transient tachypnea of the newborn. Insulin needs postpartum are cut in half with the delivery of the placenta. So when that placenta comes out, it carries with it the hormones that have been blocking insulin, and needs are generally 1/2. People with type 1 could even require 1/3 of their pregnancy doses at that once the placenta leaves. For type 2 and GDMA2, the insulin infusion should be turned off with the delivery of the placenta. For type 1s, it needs to be cut back by 1/2. So this is an important graph that I always use. It shows that all pregnancies have this experience of doubling and then tripling the amount of insulin their body requires because of insulin resistance during pregnancy. And you can see that let's see, previous. You can see that right here is the delivery of the placenta, and that their insulin requirement drops below that which it was before they even became pregnant. So this is the most insulin sensitive time, and it comes sort of back to that by the end of the week or 2 weeks. But this is what happens to all women. So if you are a type 1 and your usual requirement for insulin is up here, then you will, if your usual insulin requirement is 25 units a day, then when you are up here at double, you will need 50. So by the time you are about 26, 27 weeks, you require 50 units. Whereas by the end of pregnancy, you might require 75 units. That does not make your curve different. You will still just double and triple. So in the guidelines for care, there is a graph that shows that they actually are different on this graph, but they really are not. This is the only graph that should apply, just so you know that. And then avoiding newborn hypoglycemia in the newborn is really important, and the way that we have done it was to achieve normal glycemia during pregnancy and labor. And even the last 18 hours before the baby is born can change whether or not it will have hypoglycememia if we can keep the blood sugars in a really normal range in those last 18 hours. So there is evidence in the literature that shows that even those hours could make a big difference. So the other big difference in terms of avoiding newborn hypoglycemia is getting in breastfeeding in the first 30 minutes after birth. And there is my baby Rachel, who is turning 22 and graduating from Davis next month. And she has that same little punim, as they say in Yiddish. So avoiding hypoglycemia, dry that baby thoroughly, place it skin to skin, breastfeed early and often. Colostrum wakes up the liver so it can provide glucose when the newborn starts to drop its blood sugar. Now, Rachel, I had GDM with Rachel. Her initial blood sugar was 39. I said to the nurse, I'll break your arms and legs if you bring that baby to the nursery. Give it to me, I'll breastfeed her, she'll be fine. Her blood sugar was 50 after the breastfeeding, and she's graduating from Davis, like I said, with honors in June. So, you know, who knows what the real number is for hypoglycemia, but breastfeeding really works. So the medical goal of intrapartum is a safe and uncomplicated birth, but it also should be followed by libations. And here is our delivery table set up with champagne glasses, and I think all delivery tables should come that way so that we can celebrate a wonderful and happy birth and in no way deliver those 18-pound babies.